Is that working for you?
Perfect.
Okay, so obviously I'm sorry to disappoint, but I think this was a fairly last minute getting subbed in, so it's maybe not going to last quite as long as some of the other presentations. But what I was planning to do is just give an overview of AML from the perspective of a kind of general pediatrician with a little bit of details, but not diving too deeply into AML. It can be very complex, and it's one of those ones, the more you look at it, the more complicated it gets. So I was going to go through things systematically. So start with an introduction, go over how AML presents, how we investigate it, how we go about risk assessing. In fact, if anything, that's probably the key part of the talk. Then a bit about treatment, what we expect in terms of outcomes, and then a little bit of looking to what's the future directions for AML and what kind of conclusions can we draw from where we are today. And also, I like to start at the start. The kind of root of what we do in hematology, particularly malignant hematology, really derives from what happens in the bone marrow. I'm sure you've all come across this tree in one of its various forms at different times in your training so far. So when we're thinking about leukemia, we're thinking about how blood cells are made. So it starts off with a multipotent stem cell, a very primitive stem cell in the bone marrow niche that then can duplicate itself and mature into myeloid precursors and lymphoid precursors, and then can further differentiate into more mature cells. So these can be cells that go on to make platelets, cells that make red cells, other leukocytes on the myeloid side, so mast cells, basophils, neutrophils, eosinophils, monocytes, macrophages, among others. On the lymphoid side, you get T cells, B cells, and NK cells, among others. We like to keep things as simple as we can, but just worth being aware there is more nuance to this. Also worth just bearing in mind that we like to keep things nice and distinct in a nice separate tree where some cells become B cells and go down the lymphoid route, some cells become monocytes, go down the myeloid route, but actually there's probably reasonable amounts of crossover reasonably far down in the tree. You can go part of the way down one route, then turn back and go the other way. So just worth thinking about that for slightly more complicated cases. This is just a picture of where the magic happens. This is a picture of a bone marrow trephine. I know that some of you will have taken trephines at various times, but I'm not sure how many people actually had a look at it in the microscope. So on the trephine, what you're looking for is to see some bone. These are bone trabeculae here. These kind of wee holes in the trephine are adipocytes that would have been filled with fat. The fat is lost in the staining process, in the staining fixing process, sorry. And in between, you can see lots of different cells that are going to make lots of different types of blood cell. Some of them are quite obvious. That's probably going to be a megakaryocyte. You can see some macrophages and things in there as well. And, you know, it's kind of worthwhile just having a think about what's happening in the marrow. You get some cells which are very well fixed to the marrow. So your primitive cells, but your most primitive cells, should be stuck in the marrow and often are stuck quite close to the bone. The more mature cells tend to be less fixed, so their chemokine signaling, which keeps in the marrow, isn't quite as strong, and that can impact on what you see in the peripheral blood. So some leukemias you'll find millions in the peripheral blood, will be easy to see. The leukemias with the same disease burden might be more fixed in the bone marrow, and you have to look more specifically in the bone marrow. Okay, so moving on a bit more specifically to AML. So what is AML? It's acute myeloblastic leukemia. So kind of at its simplest level, AML is a cancer of myeloid progenitors. In common with other cancers, it's characterized by, first of all, enhanced survival. These cells don't die the way they should. You know, your bone marrow is generally very well regulated. Cells know when they can proliferate, when they should die. these cells proliferate more than they should and die.
Tony, you're just breaking up a bit there.
Is that any clearer? Maybe.
That's great, thanks.
Okay, so AML, let's come over. So a cancer of myeloid progenitors characterized by cells that don't die when they should and proliferate more than they should, and cells that, on top of that, don't differentiate the way they should. So these cells should be maturing and turning into your mature neutrophils or monocytes or eosinophils or whatever they're going to be, but instead they're stuck at a primitive phase, which causes problems. AML is a genetic disease. It's caused by chromosomal or molecular mutations. One way to think about it, it's not the only way to think about it, but it is a way I find useful, is that you get different classes of mutation. You get some, which we call type 1, which do this first thing. So you get mutations which will enhance the survival of the cell. These might be mutations in FLT3 or in the JAK kinase pathways, in the c-KIT pathways in RAS. You may also get mutations which block differentiation and keep the blast cells as blast cells and block them from other kind of mechanisms by which they might be controlled and die and stop proliferating. And those might be things like NPM1 mutations, CEBPA, RUNX1, and PML-RARA. Now, I'm not particularly expecting anyone to know what these genes do, but it's just worth bearing in mind that that's what it's mutations in these kinds of genes that cause AML, and it causes AML by these mechanisms, by causing enhanced survival and block differentiation. There are other genes that are often mutated in AML, so particular ones might be genes involved in epigenetic regulation, so controlling which genes are turned on and which genes are turned off at any one time. And AML cells often have an epigenome which is not normal. This can be triggered by mutations in genes like TET2 or IDH, or the most common one we see probably in pediatrics is the KMT2A or MLL gene. And you can also get kind of gene mutations in other genes that are just globally important for good DNA health. For example, TP53 mutation stops one of the major ways in which your cells will sense damage to DNA, and will therefore encourage the accumulation of more and more genetic changes and a more and more pathogenic AML clone. That all clear so far?
Yeah, that's good. Can I ask a wee question just there?
Yeah, of course.
So during the treatment of AML, can the molecular mutations change? So could somebody have FLT3 and later have RUNX1?
Yes, absolutely they can. What you is that you don't tend to switch within your class of mutation. So if you have a FLT3 mutation, you're unlikely to acquire a secondary KIT mutation. No, these things happen. AML is a horrible disease, often in the context of a dysregulated genome where you have lots and lots of mutations happening because you've stopped controlling your DNA. But often what you might find is you have a FLT3 with an NPM1 at diagnosis, then at relapse, you've still got your FLT3, but you've lost the NPM1 mutation. You've got another blocked differentiation that you've acquired. Or you start off with a FLT3 and you acquire a epigenetic dysregulation on top of the FLT3 mutation, giving you a kind of more aggressive or a more difficult to treat leukemia. So yeah, clonal evolution is very much a thing in AML. The same things happen in ALL as well, but AML we focus more on the mutational landscape.
Thanks very much. And sorry, just a secondary thing to that. So if you then had a mutation again, would that directly impact the treatment approach? Would your treatment change if you then had something else, a molecular mutation, basically?
Possibly. A little bit depends on where you are and what's going on at the time.
Okay.
There's a lot of these molecular changes that we're starting to get able to target. There's nothing out there yet that's absolutely got a treatment that definitely works all the time and is brilliant. but we're starting to get there. Particularly FLT3, I think, is one that's closest to being targetable, and it's one that's fairly common and often fairly bad risk. So that's something that we'll talk about a wee bit later.
That's great. Thanks a lot, Tony.
Okay. I think it's important to point out that children with AML, the disease behaves or is different to adult AML. So AML in children often associated with balanced chromosomal translocation. So about half of children will have a balanced translocation in their chromosomes, which is almost certainly one of the major drivers of the disease, though they will always have additional mutations they've acquired on top of that. But as you get older, that becomes lower and lower, the amount of chromosomal mutations that you have, and you get more and more molecular problems. So by the time you're an adolescent, you can actually quite clearly see a drop in that from about 50% to about 30%, then drops further as you get older. And in fact, if you look closely at the mutational landscape of AML, you'll find that children less than 1 have a very different molecular profile to children between 1 and 10, who are very different to between 10 and 20, who are different to older adults. Yeah, the number of molecular changes you find in the genome of AML cells increases with the age of the cell. Also worth pointing out that AML is relatively uncommon in children, but as you get older, it becomes more or less inevitable. If you live long enough, you probably will acquire AML if something else doesn't get you first. So this is just a schematic of some of the mutations you find in childhood AML. Now, I don't expect anyone to remember this. I mean, I forget most of these things. But just to point out, it is complicated. And even kind of alluded to here, you can salami slice this right down. So no two cancers really are the same. Every cancer is unique in some way. You try and divide them into groups as much as possible to allow easier treatment, but often it's difficult. It's a very heterogeneous disease. Okay, big groups we're aware of. So you get RUNX1 mutated AML, so that's a class 2 mutation, NPM1, AML, and a few others, so core binding factor mutations and things. The old-fashioned way of looking at AML, I'm putting in here just so that you know where it comes from in case you come across the terms and don't know what they mean. These are based really on morphology, so what the cells look like under a microscope. It's called the FAB, or Frank American British classification. You start off with M0, which is undifferentiated blast cells, so blast cells that don't show any signs of being anything other than the most primitive stem cells. Moving on to M1, which have very minimal signs of maturing towards the myeloid lineage. M2 are cells that look as though they're destined to become neutrophils. M3 is something we don't really consider with AML these days. It's something called APL, or acute promyelocytic leukemia. It's a disease entity that's characterized by a specific translocation that causes a fusion of the genes PML and RARA, and can be cured without using any chemotherapy and just targeting that mutation. But I'll talk about why it's important to know about it in a wee minute. M4, you start to see a bit of an in-between cell between a myeloid precursor and a monocyte precursor, so a neutrophil precursor and a monocyte precursor. And M5, you see a more mature monocyte leukemia. Then M6 is an erythroid leukemia, and M7 a megakaryocyte leukemia. So that's where these names come from. So if you hear someone talk about M4, they're talking about an AML which has some features of being a neutrophil AML and some of being a monocyte AML. Again, there's one reason to think about the FAB classification I'll talk about in a wee minute. And of course, all comes back to the hematopoietic tree. The M0 blasts often look like the multipotent stem cells. M1 somewhere between the common progenitor and the myeloblast. M2 looks like myeloblasts. M3 is APL, which is a stage beyond myeloblast. M4 somewhere between myeloblast and monocyte. M5 monocyte. M6 erythroid. not like this, but a big erythroid precursor, and M7 a megakaryoblast. So, moving on from the kind of theoretical genetics underpinning what is AML chat, how does AML present? So most of the time, AML will present with bone marrow failure, and that takes the form of anemia, or more commonly, infection, and sometimes bleeding. And the reason that it's so important to know about APL, even though we treat it very differently to other AMLs, is it can present with catastrophic bleeding. If you look into the literature around AML, it's a disease which is eminently curable. So the vast majority of people with AML, children or adults, will have a complete cure and probably don't ever need to be exposed to chemotherapy. But a significant proportion, 10 to 20%, will die before they get any treatment whatsoever. Okay, so if you ever come across a child who has bleeding, who's got pancytopenia, who you think could be leukemic, you need to think about APL. APL is an emergency, and we would give treatment as soon as we had any suspicion that someone had APL. And treatment is very fast and very effective. So, if someone's bleeding and their cell counts are lower than cytopenic with a high white cell count, think about APL. Often, children with AML get constitutional upset, almost certainly mediated by cytokines released by their leukemic blasts. This could be fevers or lethargy or any other kind of weight loss, these kind of constitutional symptoms. Occasionally, you can get children who present with leukostasis. So leukostasis means that they've got so many leukemia cells in their blood, and often it's big sticky leukemia cells, which is the only real reason I think about the FAB classification. So these are often M4 or M5, so cells that look a bit monoblastic or monocytic in origin. These can get clogged up in blood vessels, particularly in and around the brain and the eyes, and that can be an emergency. It can cause essentially, a horrific microangiopathic picture where you get organ failure secondary to leukostasis. So worth just bearing in mind if someone's presenting with funny neurological symptoms and they've got high white cell count, again, an emergency, we can treat it, we can give emergency chemotherapy, we can give steroids sometimes, or if we have to, we can do leukapheresis to remove white cells directly from the blood. And occasionally you might present, or you might get someone who presents with unusual masses that turn out to be myeloid sarcomas, which is a solid form of AML. If you remember at the start, I was talking about how some leukemias get into the blood very easily because their biology is such that they're not so stuck together or stuck to the bone marrow. Other leukemias tend to stick together or stick in the bone marrow, and they can sometimes form solid lumps of disease. And often you can get skin lesions with AML. These things are rarely presenting features, but they are things you can find in someone who otherwise presents with AML. So how do you do the initial workup for someone with AML? Well, first thing you do is a full blood count, see what the blood counts are doing, and look at a blood film. And most times, if you have a pancytopenia, if you have low blood counts, and you look at a film and see blasts, you can make a putative diagnosis of leukemia. Sometimes it's really obvious if something is an acute myeloid leukemia or an acute lymphoid leukemia, but often it's a bit more tricky. But we can send off a specialist test called flow cytometry, which looks at the markers on the surface of the cell and can tell you pretty much within a couple of hours what the diagnosis is in an acute leukemia. And that can be done on peripheral blood, though often we do it in the bone marrow as well. It's important with anyone with leukemia, but particularly with AML, and again, particularly with a view towards APL, that you check a coax screen in anyone you suspect might have leukemia. As I say, APL patients can bleed dramatically. They can bleed to death in front of your eyes, and they bleed because of an uncontrolled DIC that's really, really obvious from doing a coax screen. Other AMLs also can cause quite bad DIC, so it's worth knowing about and worth thinking about the risk of bleeding. We always keep an eye on the biochemistry and always worth sending a grouping screen in case of bleeding or in case the hemoglobin is very low. In the bone marrow, we look at the morphology, look at what the cells look like. Nowadays, we get our diagnosis really from doing the cell markers. In terms of other information we need at workup, we need to know genetics so we can then evaluate risk. So we can then think about what's this child's risk of treatment and risk of relapse, depending what treatment we give them. So we do cytogenetics, which looks at the chromosomes inside the leukemic cells, and we do molecular genetics, looking for specific targeted mutations that the AML cells might have. Just now we look for FLT3 and NPM1 mutations, but I suspect in future that will be rapidly expanded to look for a whole host of things. And finally, another part of our risk stratification is to try and measure as accurately and as deeply as possible how well children respond to the treatment we give. And to do that, we use something called minimal residual disease, or sometimes called measurable residual disease. And at the start, we will look very, very closely at the leukemia cells to try and find something that we can then use as a marker to look very, very closely at the marrow at a later time point to see if there's any leukemia left. Ideally, we want to find a molecular MRD target. So that's something that has mutated inside the AML cells, so like a FLT3 mutation or an MLL mutation, sorry, a KMT2A mutation that we can then follow up. Alternatively, we can look at the cell markers on the surface and look at a broad panel of cell markers to try and look to see if we can identify leukemic cells at a very, very low level after we started some treatment. There are pitfalls to that. So cell markers can change. So just because you have a certain signature of cell markers on your leukemic blastic presentation, you might relapse with a different signature of cell markers. And as Bubi was alluding to earlier, just because you happen to have a mutation at presentation, if you relapse, you might have a different mutation. So AML is not as easy as ALL for measuring MRD. I'm sure you've had some talks about ALL already. In acute lymphoblastic leukemia, every cell has a unique rearrangement of either its immunoglobulin receptor, the IgG locus, or its T cell receptor, and that can be traced very, very, very carefully. In AML, you have to find something that's abnormal in the cell, and that means it's more variable, less likely to find a target in the first place, and also more likely the target's going to change. We do an echo up front in children with AML because the treatment we give can be very cardiotoxic. Worth considering doing things like chest x-rays, looking for any evidence of lymph node masses. And AML is often a higher risk disease than ALL, and it's worth thinking early about considering workup for a possible bone marrow transplant or stem cell transplant. That all clear so far? Any questions just now?
Yeah, totally clear. That's good, thanks.
Okay, so at the moment, the real key decisions you have to make and the key guides to what treatment we use in AML are based around risk assessment and how risky is this disease for this child. To work out risk, we have to look at a combination of genotype and phenotype. So what is the underlying genetic disorder that's causing this cancer, causing this leukemia? And then secondary, how is this leukemia, how is this cancer responding to our treatment? And is that response good enough that we can be confident the treatment we're giving is going to continue to work and give us a cure? We're getting there. We're not quite as good at risk assessment in AML as we are at ALL yet, but using a combination of the genotype and the phenotype of a cell or of a AML, we can split into fairly even groups of a low risk. We've got a almost 75% event-free survival at 10 years to in between risk, where about 50% will have long-term cure, to high risk, where around 25% will have long-term cure. Obviously, the goal is to try and get better risk stratification and get better at treatment. But it is complicated. So again, I'm not expecting anyone to remember this. I mean, I look it up every time I want to try and work out what someone's risk is, just in case things have changed. a very rough rule of thumb is that the type 2 mutations, if they are driving a leukemia, it tends to be better risk, and the type 1 and more complex mutations tend to be poor risk. But I think the take home is it's a bit complicated, worth looking up when you have results back. And then actually putting that risk assignment into practice is tricky too. So this is what we do in our current AML trial called MyChild, where we assess risk following the first course of chemotherapy when we have all the genetic results back and the first MRD results back, and then again at the end of the second lot of chemotherapy, and then again sometimes at the end of the third lot of chemotherapy. And that's just trying to pull out all the children who we think won't respond to conventional chemotherapy, who might need something more aggressive like stem cell transplant. In the future, we'll use it for more targeted therapy as well, but we're not quite there yet in children. I'll talk through treatment in a few minutes, kind of the schema. We use a few different types of chemotherapy treatments in AML. The backbone of AML treatment has been for 30, 40, even longer years, is the combination of an anthracycline agent, which is a topoisomerase inhibitor, which causes double-stranded DNA breaks in leukemia cells, and aracitabine, which is a nucleoside analog, which causes abnormal nucleosides to get integrated into tumor DNA, triggering cell death that way. So these integrate into the DNA of dividing cells and hopefully will then cause the cells to die by triggering apoptosis. The traditional regimen we use in adults is called DA. It's daunorubicin and aracitabine. In children, we tend to use MA, which is mitoxantrone, and aracitabine. We use mitoxantrone in children because it's meant to be less cardiotoxic. There's a little bit of evidence for that. A more intensive regimen we use in high-risk children is fludarabine, which is another nucleoside analog, a higher dose aracitabine, and idarubicin, a slightly more intensive anthracycline drug. And sometimes for maintenance, to try and deepen our remission, we might use high-dose aracitabine. In some children, chemotherapy will not cure their AML. The current alternative to chemotherapy that we use in routine practice is stem cell transplant. This, in theory, works by inducing a graft versus leukemia effect. So you're effectively introducing a foreign immune system that should hopefully be able to recognize AML as foreign and fight it off immunologically. But it's a very risky procedure to go through. And worth pointing out, one of the differences to how we treat adults is in children we are a lot more aware of the risk of CNS relapse. I suspect it's probably to do with the fact that we have better outcomes overall. So we actually see children live to get their CNS relapses, whereas in adults, outcomes are much poorer in general. But we give all children CNS prophylaxis. There are novel agents on the way. So in routine practice now is an antibody therapy called gemtuzumab oxygomycin. So we use that in our current myeloid patient, AML patients in our myeloid trial. We're just not quite sure yet what the optimal dosing regimens are for it. There is good evidence it is effective though. More in the pipeline are small molecule inhibitors. FLT3 inhibition has been shown in adults to be effective in treating AML, and we are in the process of starting trials in children, but certainly so far there's no good evidence in children for any of these agents. BCL2 is a little bit different in that it doesn't target a specific genetic change. It just helps encourage apoptosis overall. So BCL2 is a apoptosis inhibitor. By inhibiting an apoptosis inhibitor, we encourage apoptosis overall. So in combination with conventional chemotherapy, that can help augment responses in AML. Again, that's been shown in adults, but it hasn't been shown in children yet. So it is becoming a standard third or fourth line treatment to try a BCL2 inhibition on top of some other therapy, for example, cytarabine. And finally, there is some work going on trying to get a chimeric antigen receptor T-cell therapy against AML that's reasonably far advanced, but there's no good evidence, certainly in children so far. What does the treatment do to children? Well, apart from hopefully curing the leukemia, almost every agent we use causes bone marrow suppression, and that carries with it, the risk of needing lots of blood transfusions or platelet transfusions. There's risks of bleeding, and more than anything else, there's risks of infection. So we're going to cause severe myelosuppression. During our induction chemotherapy, children will often have no neutrophil count for more than 7 weeks, and the risk of infection is very high. On top of that, the chemotherapy is often immunosuppressant as well, particularly fludarabine is very, very good at depleting lymphocytes as well as depleting neutrophils. So these children have no real defense against infection. We have to be very, very careful with them. You can get very bad GI toxicity. The anthracyclines that we use quite a lot of in quite high doses can cause cardiac toxicity. That's one of the major limiting factors in our treatment of children with AML. And as well as all this, there are potential late effects, of which the most dramatic is probably secondary cancers in 10, 15, 20 years down the line. And this is our current treatment schema on the MyChild trial. So we start off with MA, so mitoxantrone and aracytarabine, plus the gemtuzumab, the antibody therapy that we're trying to find the right dosing regimen for. By the time we've got through the first course, we expect to know whether someone's high risk or not high risk, and high risk will be determined by the fact that either they have bad genetics that we found, or we haven't managed to induce a good remission. Either of those things is a very high risk feature, and if you're high risk, you get more intensive chemotherapy and you get a stem cell transplant. If you're not high risk, you then get reassessed at the end of course 2, either into standard risk, or intermediate risk, or high risk. High risk get a transplant. Intermediate risk gets more treatment, then reassessed into high risk or good risk. Any questions just now? I'll take that as a no. Oh, can I say something?
I was just going to say, I don't think so, Tony. Thanks.
Okay. So what kind of outcomes do we expect to get in children with AML? So I think if you had to put a rough number on it, we expect somewhere between 60 and 70% overall survival in the long term, which is, not absolutely terrible, but also it's not really where we want to be in terms of treating leukemia. Event-free survival is 50 to 60%, so that's children who have had their treatment and not relapsed. And relapse happens in somewhere between 35 to 40% of children. Looking at the numbers in a bit more depth, we say less than 2% induction death, but that's still somewhere around 2% of children who will die because of the chemotherapy we give them up front. 5 to 10% of children will have disease that just never responds to anything we do. Yeah. And as I say, a significant portion will relapse, and of the ones that relapse, a significant portion will never be salvageable. So if they go into relapse, we will never be able to then get rid of the disease again and get them cured. When we use stem cell transplant in children who have AML, we very, very clearly reduce the risk of relapse. So transplant works very, very well at reducing relapse risk in AML. There is a good graft versus leukemia effect in AML, probably more so than there is in ALL. But transplant is risky. It's a very dangerous procedure, and that's a high treatment-related mortality. So people can die of infection. They can die from graft versus host disease, where the new immune system causes organ damage to the recipient. And when you look at the numbers in children with good risk AML, you're better off not getting a stem cell transplant because the transplant rate of mortality outweighs any benefit in terms of reduced relapse risk. Likewise, intermediate risk is a bit in between, but probably you're as well sticking to chemotherapy and taking your chances. But with high-risk disease, there's a clear advantage to giving stem cell transplant because despite the fact that you do introduce the risk of treatment-related mortality, the risk of relapse is so high, the risk of death without it is so high at around 75%, that it's worthwhile trying to pull that up with a transplant. Also worth noting that not quite year on year, but every 5 to 10 years, you can see a clear improvement in treatment-related mortality following transplant. We are getting better at the supportive care you need to have a successful stem cell transplant, but it's slow progress. It takes time to get there. And again, just kind of pointing out how important good risk stratification is in terms of predicting outcome and therefore predicting what treatment will be best for that particular child in front of you. Looking to the future, so I think the kind of way forward with AML over the next probably 10, 15 years will be improved risk stratification and crucially improved treatment stratification and improved use of new agents on top of what we do already as we get a better understanding and more routine clinical practice looking at the molecular landscape of an individual's AML. The other thing that will hopefully improve our outcomes is improved supportive care, particularly around stem cell transplant and allograft as it's known otherwise. And the other thing that we're going to have to get better and better at is that AML is rare and we have lots and lots of potential new treatment options. And the only way we can work out what the best treatment is, what the best timing of treatment is through clinical trials. And we'll have to have large-scale, international, and complicated trials to try and tease all this out. And it's going to be difficult. It's going to take a long time, I think. So in terms of conclusions or take-home messages, I think you sometimes hear people talk about AML as the bad leukemia. And I don't think that's entirely fair. Overall, AML has a poorer outcome than ALL, and ALL is more common. We're more used to dealing with it. But a good risk AML probably has as good an outcome as a bad risk ALL. So I think it's not quite as easy as lumping into good and bad. AML is a very, very quickly moving field. You know, we're getting lots and lots of things we can potentially target. Lots and lots of new agents are coming online. I think over the last 5, 6 years, there's at least a dozen new agents that weren't available before. But numbers are small. You know, getting the trials is difficult. You need kind of large international collaborations. So my child involves the UK and France and Australia and others. And it's often difficult to try and build these protocols across international borders against what people have been used to doing for years and decades. And it's difficult to know how and when we introduce novel agents. So do we start introducing FLT3 agents up front? But what about the MLL inhibitors? What about, you know, the BCL2 inhibitors? Where do you start? And how do you design your trials to maximize the speed at which you can show which treatments work, which treatments don't work, and which children get which? And I think an important point that's difficult, that's important not to overlook, is that AML is common in adults as far as cancers go. Almost all of the the work we have, all the updates we have in AML have come via the adults. So the use of FLT3 inhibitors, the gemtuzumab antibody that we use. But as we noted at the start, adult AML and childhood AML are very, very different in terms of their biology. And we just have to bear in mind that things that work in adults might not work in children. And we can't just assume that what we do in adults is the right thing to do in children. And I think that was just about all I wanted to cover today. Does anyone have any questions or anything else they want to talk about?
Yes, Tony. I was just wondering on your last point, saying that there's a difference between or some difference at least between the AML seen in children and adults. Is that something that's purely down to the genetics that we see? I know that with things like MLL genes and how they may manifest themselves, especially in the youngest, the under ones, they can kind of give more primordial difficulties to manage phenotypes. But is there anything else in addition, apart from the fact that as adults they might also have less reserve and multiple comorbidities in terms of their treatment?
I think, we're at the infancy of truly understanding the relationship between genotype and phenotype. That's why we have to measure both in order to make good judgments about risk. What we can say now is that in adults, we're much more likely to find something we can target because it's such a molecular-based disease, so that kind of all adults will have mutations, and a lot of them will have mutations we can target. Children, it's less clear cut. Often it's a kind of chromosomal-based disease, which overall is probably better. These children, by and large, respond better than adults to treatment. But I think understanding the true nuances of what is different about childhood AML as opposed to adult AML isn't clear yet. But I think it's just worth bearing in mind when we're trying to apply treatments developed for adults in childhood AML, we might not get the same results. There clearly are differences in biology. And likewise, trying to apply childhood ALL treatments to adult ALL doesn't work particularly well either.
That's great. Thanks very much, Tony. I can't see any other questions cropping up at the moment. So no, I thought it was a really good talk, and thanks for going over it. I think it's difficult to do an overview. It's like in such a complex disease, but I think you made that make quite a lot of sense. So thanks for preparing the talk and doing that today.
No worries.
Thanks.
So thanks for the invite.
Sorry, Tony, on you go.
I said just thanks for the invite.
Oh no, no problem. Yeah, thanks to everyone that attended. Just as usual, again, everyone that's here, if you've just got a minute, there's a Survey Monkey that you should have got from an email from Victoria Sanderson just to give some feedback. Should only take a minute or so to complete. So thanks again. See you later, Tony.
Cheers. See you later.
Thanks.
Thanks, Tony.